Hello and welcome everyone to tonight's webinar on self-care for health practitioners. I'm Dr. Leonie Harcourt, a GP Education Advisor at Capital Health Network. Also with me tonight is Kunal Mohiti, the Events Lead at Capital Health Network, and of course our expert speaker, Psychologist Lucy Archinal-Hudson. First, I would like to acknowledge the traditional custodians of the land we are meeting on. I acknowledge and respect their enduring culture and the contribution they make to the life of this city and this region. And I pay my respects to their elders, past and present, and also would like to acknowledge and welcome other Aboriginal and Torres Strait Islander people who may be attending tonight's event. So onto the housekeeping part. All participants or attendees have been muted. Please type your questions into the Q&A section on the Zoom window, not in the chat box. Lucy has kindly agreed to answer questions as they arise throughout the presentation, so I'll interrupt her at a good time. And the presentation itself will be uploaded to the Capital Health Network YouTube page, and you're welcome to share it with your networks or rewatch bits that you may have missed and you want to review. Regarding CPD, please fill in the post-event evaluation survey that CHN will email to you. We'll also email a certificate of attendance after the event. And please feel free to self-report 1.5 hours of educational activities to your CPD home. So now over to our speaker, Lucy Archinal-Hudson. Lucy is a clinical psychologist. She has worked with clients across many contexts, including the public sector, education, forensic and police settings, and out-of-home care. Lucy currently works full-time in private practice in civic and has a special interest in neurodivergence, perfectionism, and burnout. So very well qualified to talk tonight. So I'll hand over to Lucy now to start the presentation. Thanks, Lucy.
Thank you, Leonie, and thank you all for joining me tonight. I think it's actually such a lovely thing to take time out of your day. I know it's the evening, especially to actually put yourself first and thinking about your own self-care. So well done, all of you guys, for coming. So tonight we're going to be talking about burnout, vicarious trauma, and compassion fatigue. Some of you, if you've been working in health for a long time, might be familiar with some of those terms. Hopefully, we can still give you some interesting ideas, and you might learn something new. If you're sitting there thinking, I'm so burnt out, I'm going to leave, this health setting, I'm going to go stock shelves at Woolies, that would be better unless this webinar changes my life. I've been there. Hopefully I don't know if I can promise it will change your life, but I can promise that I've been there, and I'm certainly going to talk about what my burnout recovery looked like, and hopefully what yours can as well. I would also like to acknowledge that we're meeting on Aboriginal lands tonight, the Ngunnawal and Ngambri people. I especially think it's particularly important at the moment. I think when we're talking about vicarious trauma, we're actually witnessing so many people across the world be displaced, and it's also happened here in our own country. So I think it's actually really, really relevant to what we're talking about. And a little bit about me. So yes, I'm a clinical psychologist. I've worked in lots of different settings where I was exposed to vicarious trauma. And if you're not sure even what that term means, that's all good. We'll get to that in a minute. And I'm neurodivergent myself. So just a bit of a caveat that neurodivergent people are especially prone to burnout. And we can talk a little bit about why. But this session will predominantly just talk about burnout in general, not especially neurodivergent burnout. But if you're neurodivergent and you're here, I see you. Very happy to answer any questions. So we're here for about the next hour, and I really want you to know that this is a safe learning space. You can ask questions. There's no video, so I think Bianca posted something, but there's no video. We can't see you, no one else can see you, so you're welcome to stand up, stretch, use focus items, take a break if you need, eat, drink, use pets and all that sort of stuff, because this is a space for you. And I love that you guys are putting yourself first, potentially, maybe for, a change. All right, so let's get stuck into it. So I guess I want to preface this with this slide by saying that with everything that we're talking about tonight, it really is on a continuum. So there's good bits of our work and there's bad bits. And if you kind of notice throughout the night that, oh my gosh, I'm actually kind of sort of further down the right side of things, please know that, it's a continuum. You will go up and down throughout your careers. And if you're feeling like you're down that end, we absolutely can do things to come back the other end. So when we're thinking about stress, at the really extreme end, when we're exposed to too much stress, without recovery time, that can absolutely lead to burnout. But on the other hand, some exposure to stress where we get ample recovery time, where we're sort of pushed outside our window of tolerance a little bit in our comfort zone, but then we can re-regulate, we can learn and improve and grow, that's actually really good. If we weren't exposed to stress at all, we wouldn't develop sort of resilience and ability to withstand stresses in the future. So stress itself is not a bad thing. We're just looking at those two extremes. Similarly, in caring professions, it's on a continuum. So at one end, we've got empathy, which can be very nice to experience. We can, feel a lot of compassion for other people. It can really make us feel good about ourselves and the world, our community, our network. But on the other end of the spectrum, we can actually become quite burnt out from being a carer. And we're going to look at that, and that's called compassion fatigue. And similarly with exposure to trauma. So on the sort of positive end of the spectrum, being exposed to other people's trauma can actually lead to vicarious post-traumatic growth. So changes in our worldview, changes in our priorities, really prioritizing different things, family life, things like that. Whereas on the other side of the spectrum, if we're exposed to too much vicarious trauma, so other people's trauma, we can actually become traumatized ourselves. And that might be called PTSD in some people, or it might be vicarious trauma. So what is compassion fatigue? So compassion fatigue is what, most people talk about, but it's really interesting. A lot of the research is saying that compassion does not fatigue. It's actually our empathy that fatigues. And the difference being compassion is something that we can give to another person, whereas empathy is something more that happens to us. And if it's our nervous systems and if it's ourselves that are on the line, then that's when we start to fatigue. So compassion fatigue or empathy fatigue is basically when you've given so much, you've really got nothing left to give. You've given, you've given, you've given. You are someone who thinks about clients outside of hours. You have really high standards for yourself and your team. You really want to achieve a lot. Maybe you're co-regulating a lot of the time. You're around people who are constantly in crisis. You're around people that might be beyond your scope. And we're carrying so much that there's just nothing left in the tank. And that is completely actually normal and really, really common. So if there's one thing I want you to take away from today, it's not that if you experience any of these things, compassion fatigue, vicarious trauma, or burnout, that it means that you're weak or that there's something wrong with you. Not at all. It's very, very common in caring professions. So when we are experiencing compassion fatigue, it's things like we're wanting to avoid, wanting to call in sick, wanting to avoid that particular client. We can feel more detached. So, for example, when I was working in child protection, compassion fatigue might look like being exposed to horrific, stories of trauma and abuse, and kind of thinking, well, that's that. I've heard that before. That doesn't really shock me. Just feeling quite detached. And not having that sort of emotional reaction that one would expect to hearing really quite horrific things. So if you think about that as detachment. We can also experience a reduced sense of meaning, purpose, and accomplishment. So what's the point? What even is this going to do anyway? If I help this person, are they just going to, go straight back onto, meeting up with their dealer? If I'm working with this child, they're just going straight back home into an abusive environment. What's the point of what I'm doing with them at school? So some of those kind of thoughts. And also changes in our beliefs, expectations, and assumptions. So, the world is unsafe, people are bad, what's the point? Some of those sorts of things. On the other hand, burnout is not just related to caring professions. Any profession can experience burnout, and burnout is when we're at that utter level of physical and emotional fatigue. We've just been running on empty for a really long time, not in terms of caring for a long time, but just in terms of admin tasks, workload, expectations, things like that. It's characterized by a few things. So physical fatigue being one, poor kind of work and not being very efficient. In the workplace and things like that. We've also got things like resentfulness, so becoming very irritable, very cranky with a lot of your coworkers, that real cynical attitude, calling in sick, being late, kind of not caring as much, which can actually be a real challenge for a lot of people who are in caring professions, because often people in caring professions are quite high achieving. They have an identity with where they really care about other people, and that's really important to them. So then when they start to actually detach and start to actually not be as effective, then it triggers a lot of, negative self-esteem, negative self-worth. So it kind of actually compounding it based on sort of the personality types that are tend to be drawn to caring professions. Physical symptoms is really common. So things like, poor sleep, headaches, tummy upsets, lots of, gastrointestinal issues. And obviously, we certainly want to get lots of, if there's any of those things presenting, we want to get them ruled out from doctors. But sometimes they come back and they say, actually, it's just stress. And that is actually, yeah, a very common sign of burnout. waking from sleep unrefreshed. So even if, you've had 11 hours, on the weekend and you're just still not feeling refreshed. Social withdrawal, so just not having the social battery to kind of be around people. Things feel like an effort. Oh gosh, going to that family barbecue or texting that friend back. These are all signs of burnout. Relying more on stimulants, so like coffee and things like that, energy drinks, difficulty concentrating, and reduced job satisfaction. So that's,
Um,
yes.
yeah, Lucy, we have a question.
Oh, great.
Yeah, and so the question is, where and how does moral injury fit in along the continuum?
Oh, we're going to come to moral injury, so I might park that question if that's okay.
Yeah.
I'll write that down on a post-it note on my pad so I don't forget. So that's kind of what some of the definition of burnout is. If you follow the DSM-5 in your work, burnout is not actually considered a mental concern within the DSM-5, but it is within the ICD-10. So it's, I think we're up to ICD-11 now. So the International Classification of Diseases, which is more commonly used in Europe, it actually is considered a clinical term, which actually has a lot of, I've got a colleague in Europe, and it's quite interesting because given that it is in their kind of big book of mental disorders, it falls under the Disability Act, whereas in Australia, because it's not in our DSM, so really quite interesting stuff. So that's kind of, I guess, the clinical definition. What does it actually look like? So we're talking about things like, absolute dread at going to work, having thoughts about, oh my gosh, I want to call in sick, procrastinating, put everything that you can off, counting down the days to annual leave, feeling really overwhelmed, engaging in what's called revenge bedtime procrastination, which is where you're kind of suddenly at nighttime, where you might, especially if you're a parent, have finally the only time that you have to yourself in the day, and you stay up on your phone for hours, even though you know that it means you're going to get less sleep, even though you're so physically exhausted. And the theory behind this idea is that it's actually you kind of reclaiming your autonomy a little bit. Like suddenly I've got no demands on my time. No one needs me. I don't have to reply to emails because it's 11 p.m. and that's not expected. So then you're kind of clawing it back and saying, no, this is my time. I need autonomy. I need time to myself. And so kind of if you're noticing that that's a pattern for you, then we certainly actually want to be getting that earlier in the day. So super important to, take things like your lunch break, finishing work on time, things that also give you that sense of autonomy over your time and your calendar, such that then you're not having to do it at the only free time, which might be, 11 p.m. to 1 a.m. at nighttime, which is then going to compound everything because you're so exhausted. Relying on coffee to switch on, and alcohol to switch off. And this is a really common one, second last point. So I hear this all the time because one of the questions I most commonly get is what's the difference between burnout and depression? Because they can look very similar. There's low motivation, there's apathy, there's social withdrawal, things like that. And so often people might come to me and say I actually just want to get in a car accident. And it's not that they want to end their life. It's not a suicidal thought. It's just they need to escape their life. So they still want to be living, but their current structure is absolutely not working for them. So it's a really awful state to be in. And, I'm sure there's going to be people watching who are in this right now or have felt like this. It really takes over your entire life. Weekends feel like you're just in recovery from the week or preparing for the week ahead. So it's a really awful feeling. In terms of what causes burnout, there's internal factors, so things about us as individuals, and then there's also systemic factors. So systemic factors are things that the individual may or may not have control over. So, and the reason why I've got these little, little warning signs on the slide is because so often organizations want to fix burnout only through the internal factors. They place heavy emphasis on self-care, or, you need to kind of fix your own stuff, or that's just your perfectionism coming into play, when actually it's the systemic factors. So huge, huge caveat that tonight we're only really going to be talking about the internal factors because that's what you as a health professional have control over. But if you do lead a team, or if you are part of a large organization, really be remembering that burnout it can't be cured through internal factors alone, because it's not caused by internal factors alone. So things like systemic factors would be when there's an unrealistic workload. So when your capacity far exceeds your demands. It's really interesting because things like driving is something I've seen where even though the person is kind of alone in their car, but they're doing lots of house visits and they're expected to do 10 a day and they can only kind of make it work if they do that, and then they don't really get a lunch break, and they're driving from north side to south side and all sorts of things. And the organization is kind of thinking, but you're just sitting in the car, like, surely that's a break. But it's not. It's work time. They're thinking about their next thing. There's time pressure because they're trying to work out a schedule. So demand far exceeding capacity is a huge systemic factor. Poor workplace culture. So if there's not a culture of supportive debriefing, or if there's quite toxic culture and not feeling like you can actually have the psychological safety to say, hey, I need to debrief this, or hey, I made a mistake, I want to talk about it. Time pressures, poor support from leaders, role conflict. So that's when, you're actually not sure what you need to do or what you have control over, or if what you're expected to do doesn't fall within your scope. This can happen not just from the organization, but often from the clients that we're working with. So if you're a social worker and you're in a school and they're expecting you to do all these things that actually might be more appropriate that a teacher or a learning aid might be, that can actually cause a lot of stress within us. A sense of powerlessness. So if you're working in things like, drug and alcohol, child protection, things where there's a lot of legislation or there's a lot of red tape, and you want to help this person, but it's not within your control, that's a huge cause of burnout. Surface acting. So this is actually quite new in the burnout research. So it's surface acting is where we feel like we have to constantly be putting on a face, either to co-regulate with our clients or in order to be perceived as, friendly and welcoming and non-judgmental. And most people in a health profession do surface act. We want to be kind, we want to be empathetic. Even if the person before just really pissed us off, and we've got to pick up our kids at 5, and so actually constantly feeling the need to wear a bit of a mask and not be able to show your true self, which is very appropriate in our work as a psychologist. When I'm talking to my clients, it's absolutely not appropriate for me to bring my stuff to the session, but it is a known cause of burnout. Moral injury. So this is where we're exposed to things that really go against our values, our morals, very common in the police force. And we'll talk about that more when we come to vicarious trauma, the different things that we're exposed to. But it also, for me, for example, moral injury, I have a lot of experience in ADHD. And if I go into a school and I see an ADHD child who's being discriminated against, who's being bullied, who's not being supported, that's really going to impact me. And lack of autonomy and ability to make our decisions. So they're the sort of organizational factors. But in terms of internal factors, so things that we can control, which would be things like how much we feel enmeshed with the client. So things like how much do we see ourselves in them? How much do we go into that rescuer role? How much do we believe, I'm the only person that can help, maybe because of your own trauma background, or so for example, I'm a person with ADHD. If I'm also supporting a client with ADHD and I see myself in a lot of their things, maybe they're having problems in their marriage, which is really common in ADHD, and maybe I experience that, and so I really sort of the lines start to blur. That can actually cause burnout because you're thinking about them more, you're expending a lot more mental energy, you're expending a lot more compassion fatigue. Escalation of responsibility, so being required to do something outside your role. If we're dealing with people in crisis, sometimes escalation of responsibility happens, and that can be a source of stress. Perfectionism and unrelenting standards. So how much do we actually, I was going to say care about the work, but that's wrong. It's how much are we comfortable with giving good enough versus 100% every time. And I like to say to my clients, there's nothing wrong with having high standards. I've got high standards. Many of you have high standards, but the problem is, are the standards flexible? Do they go down when we're burnt out? Do they go down when we're sick? Do they go down at 3 p.m. when, we need a coffee? Do we actually kind of allow ourselves some self-compassion to say that, well, my capacity fluctuates, or do we set ourselves that really high standard all the time? And at the very end, when we sort of talk about strategies, I'll come back to perfectionism because I think it's a really strong cause of burnout, certainly, in myself and the clients that I've work with. Feeling ineffective, having poor boundaries, so staying back late, giving clients personal phone numbers, things like that. Having a lack of purpose, that can be a source of burnout. So we can have burnout from, work overload. That's what most people think. But we can also have burnout from feeling kind of a bit bored, or a bit just, not fulfilled, not satisfied in the work, which is one that most people we don't talk about that as much. Self-sacrifice tendencies and people pleasing / going into the rescuer role. So when we think about the difference, so burnout can occur without compassion fatigue. You can be burnt out as a truck driver, as a lawyer, as someone who's not in a caring profession. However, compassion fatigue really does commonly occur with burnout. Burnout is really chronic. It happens slowly over time. It doesn't happen overnight, which often means the recovery is not overnight too, which, can be frustrating. And also compassion fatigue, on the other hand, can be quite acute. It can be, one specific family, one specific client. When I was working a lot in sexual assault, I had a lot of compassion fatigue for that particular presentation, but not for other things, because as we'll talk about, actually getting variety in things can be a protective factor. So that's compassion fatigue and burnout. Next, we're going to talk about vicarious trauma. So vicarious trauma is basically someone else's trauma that we have seen, heard about, read about, seen on TV, read in a case note, anything where it didn't happen to us, but we're exposed to it, and maybe we then start to be impacted by it. So I think I've got some examples here. So, and it almost causes, well, it does cause a trauma response in us. And at very extreme levels, people can get a PTSD diagnosis sometimes. So in our work, gosh, there's so many examples of it. We are exposed to vicarious trauma daily. It's being exposed to the suffering of other people. It's caring for those, with cognitive decline, particularly when it's not within our control. We're not their neurologist or neuropsychologist. We're their physiotherapist or we're their counselor. So again, if there's lack of kind of control or autonomy or ability to kind of help, that can also really impact us. Case notes and histories. So some people might, I've had people come to me with vicarious trauma who read something in a case note. And so certainly, when we're writing down things, depending on your context, sometimes we need to write absolutely, in factual detail, in forensic settings, for example. In others, maybe not so much, and maybe we can be conscious of what we do write down. I like to sort of think when we're talking about or sharing stories, if you're debriefing with a friend, who, or another health colleague, we sort of want to talk about feelings, not facts. So if someone can picture it, it's too detailed, basically. But obviously in our work, sometimes we have to do that. End of life decisions, clients with financial hardship, clients who are fighting, all sorts of things that we can be exposed to. So as I mentioned, vicarious trauma is traumatic stress. So it's very similar to PTSD. So things like intrusive reactions, so flashbacks, nightmares, kind of an image that you can't get out of your mind. Avoidant reactions, so, avoiding anything that might trigger it. If, there was a client who, so for example, I've done EAP work for an organization that investigates crime scene, not crime scene, plane crash investigations. And so I would have this client talk about all these plane crashes, and that started to actually cause a reaction in me around planes, and I don't know if I want to fly to Queensland. That actually causes some anxiety in me. And so that's an example of my own vicarious trauma. Also things like hyperarousal, so being hypervigilant, feeling, constantly kind of jittery, on edge, a lot of physiological reactions. And also cognitive changes. So things like if you work in so what's an example? So for example, like in sexual assault, we know that about 1 in 7 stepfathers do assault their stepdaughters. And if you then started to be very wary of every stepfather that you were around, or if you were worked in a rape crisis center and you became very wary of ever being alone, outside, or, certain things where you've heard so much from other people that it really causes a behavioral change within you and your level of feeling safe in the world, or your level of sort of feeling vulnerable to harm and things like that. Culturally, trauma, as we know, can manifest very differently for a lot of different cultures. It's much more somatic, and it's about the physical feelings. So of course that can manifest differently. In terms of risk factors, so I kind of want you to scan through this list and see, am I at risk? Because knowing our risk factors is a really important way to protect against vicarious trauma. And as you'll see from this list, there's so many different things. So our own coping styles, are we avoidant copers or are we problem-focused copers? So do we want to, cope through regulating emotions, like, journaling, doing deep breathing, or are we problem solvers? We want to cope by, action and doing the thing. Our own personal trauma history. If If there's things, so for example, my mum passed away from cancer. In my private practice, I don't see anyone who is a carer for someone going through cancer because my own trauma history would really impact me. And there's nothing wrong with that. I'm a human being, so are you. We've all got our stuff. We just have to know it, so that we can do something differently. Our own life stresses. Are we going through a divorce? Have we just had a baby? Things like that. Lack of recovery time between clients. So there's a lot of evidence that if you're going straight from one client to another without a break, even if it's just 2, 3, 4, 5 minutes, that lack of recovery time, and on the flip side, the presence of recovery time is a huge protective factor. Gender, so women are more at risk of vicarious trauma compared to men. But the studies, I really kind of question that because a lot of them are sort of what like wider prevalence, and I think women do tend to be in caring professions more, so therefore you would see more women who have experienced vicarious trauma rather than it being a sort of personality factor. Um, the level of exposure. So, how much time are you spending with them? Is it, a 15-minute GP appointment versus a 50-minute psychologist appointment? So, time, your role and how much control you have, your age. So, younger people are more likely to experience vicarious trauma. Also, the trauma severity and type, and importantly, the client style. Are they an emotion focused coper or are they a problem focused coper? How are they coping? And do we feel the need to rescue them, or are we witnessing them rescue themselves? All those things really play a part. And as you'll see here, personal factors related to just us as an individual is actually only one of these four things. There's also the organization, there's the trauma itself, there's the person or the patient, the client, as well as us as an individual. So truly, if there's one thing that you take away from tonight, please let it be that vicarious trauma, compassion fatigue, burnout, they are related to so many factors above and beyond our control. So if we experience any of these things, we are not weak. It's very, very normal. And so often it's things out of our control. When we think about sort of signs of vicarious trauma, it's also other things like, constant rumination. Did I do enough? My God, there was that client from 5 years ago and I'm still thinking about them. Our escalation of responsibility, things like, they have to do X or I've failed. They have to have done their homework or I've failed. They have to be able to regain control of that, foot or I've failed. So really sort of placing these if-then type thinking. Cognitive changes, as I mentioned, the world is unsafe. It's not good to get close to people because they die. That was something that when I was working in a suicide response organization, there was a lot of staff who might feel that way. My gosh, suicide rates are very high. Therefore, I'm really not going to get close to people because there's a risk that I would be grieving, that I would lose them. So things like that. Personification, so things like, I'm the only one that can help them, or they've got similar life circumstances to me, or, really kind of seeing yourself in them.
Lucy,
Using,
could I
yeah,
interrupt?
yes.
Going back to the escalation of responsibility, as
Mhm.
GPs, we often have patients who don't necessarily comply with our recommendations, and sometimes they didn't take their cholesterol medication at a high level, so it's not an urgent or acute thing. But sometimes it's things like, I really think you need to go to hospital. You're seriously sick. If you don't go to
Mm,
hospital, you could, do a lot of harm to yourself. Or I really think you need to have a colonoscopy. This could be cancer. And patients sometimes don't comply with those. What strategies would you recommend for medical professionals and other professionals in such situations? Because I think we do tend to take those home and
mm.
feel responsible for our patients. We've informed them of the risks, but we feel responsible for them not making decisions that we would recommend.
Great question. And it happens in the psych world as well. Absolutely. So I think, yes, there's sort of two ways I would want to answer that. So one would be in order to be able to kind of let something go, sometimes we need to feel like we have done all that we can. And so the first kind of thing I would mention would be around, do you feel like you've got skills around motivational interviewing? Do you have those back pocket questions that kind of roll off your tongue, such as, what are the barriers that would prevent you from doing this? Or what are some of the things that are going to get in the way of, from our conversation today, to it actually happening? Does the client, have that insight? Are they aware of what the benefits would be? Are they aware of, their barriers and kind of workshopping it with them? Because then that might be a way for you to feel more comfortable that, you have done everything that you can. Also the teach back method. So for example, asking the client to repeat back to you when you've explained risks or what might happen, if they don't have this colonoscopy, we can't be sure it's cancer. Kind of asking them, can you repeat that back to me just so I can be clear that you've understood that, which is obviously a really good practice anyway, but it also really helps us cement that this isn't something that is within our control. They are aware of the risks, they are aware of the consequences, and then it is ultimately up to them. So I think, yeah, that's the first way to answer that question. Do you have the skills to feel confident? And then the second one is the acceptance piece around if you have done all of that, if you've documented it, if it's in your case notes, being able to kind of actually let that go. And there are some really good strategies. Actually, I might put in the chat at the end. There's a social worker in the US who does a lot of research about this, particularly with drug addiction. So clients who you're trying to help with addiction and it's not being successful. And she's got like a list of 5 questions, and she calls it like letting go while holding on. I think that's what it is. And it's questions such as, what would this person, how would they describe me? So, they would describe me as conscientious, or they would describe me as really caring about them and their situation, and just all things that help to create a little bit of that psychological distance. So it's their decision, it's their autonomy. I feel like I've done everything that I can. And I'll put those in the chat. Okay.
Thanks.
All right. And finally, poor boundaries. So things like, gosh, I hope this doesn't happen to anyone, but, availability outside of hours, befriending clients or patients on social media, things like that. In terms of reducing the risk of vicarious trauma, I will run through this really, really quickly because I'm very keen to get on to burnout. But it's things like, knowing your triggers, knowing your signs and symptoms, so you can actually act on them. So many people, they sort of, it's not until crisis point that they've really realized something is going on. So actually really knowing your signs and symptoms. So is it, I get a jolt when I see that name on my, in my practice management software? Is it that I'm starting to feel like I don't have time to read my book of an evening because life, my brain is just not switching off? Is it that I'm, like one of mine, this is really silly, but I really love sauna as part of my self-care. And I know that I'm starting to feel really overworked and really chaotic when I'm like, oh, I can't go because I don't have time to wash my hair afterwards. And it's like, I absolutely do have time. I can make time, I can go earlier, but it's just that internal restlessness of go, 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 go. So yeah, when I'm saying to myself, I can't go to the sauna, that's one of my personal ones. And that's what I mean about knowing your awareness. It's going to be so unique to you. We can talk about, sort of big signs. You're sleeping badly, you've got low appetite, and absolutely they apply. But what are yours? What are your really unique things? Self-care, we're going to talk about clarity, ethical boundaries, work-life balance, be more than your role, sort of have interests and roles outside your work and volunteering. When I was a student, I was in a placement in youth justice. I then was volunteering at a charity as like a mentor to a child who had lost a parent. And so I was studying. So I was doing unpaid work in youth justice. I was volunteering for this charity. I was doing paid work at the ACT Human Rights Commission in their witness intermediary program. And it was just trauma from all these sources, from my paid work, from my student work, from my volunteering. And I didn't see it at the time, but it's so simple. But if you're doing your work in all these other areas, you're just so much more at risk. So having that work-life balance, if at work you are a doctor, don't volunteer for Doctors Without Borders. Certainly sometimes in life that might be appropriate if you've got all sorts of lifestyle factors working out, but volunteer as a dog walker, or don't volunteer at all, because there'd be people here who actually probably give too much, as we're going to talk about. Focus on giving your clients the tools. So we do this, in psychology, really important that if we're doing something like an imagery exercise, we record it, we give it to them, we give them a handout, we give them things so that they're building up their toolbox rather than relying on us. Getting variety at work. Obviously, this is really easy for me to say. I work for myself, but within your work, can you work with adults and kids? Can you work with, oncology and psychiatry? Can you work with feet and hands? Struggle to think of another body part then. Seeking social support, so debriefing with colleagues, training opportunities, and if you need it, seek your own therapy. And just very quickly before we move on to burnout, so there's a nice little framework, ABC, so awareness, balance, and connection. And I really like that, remembering that, trauma is not the whole part of our work. Sometimes we have that recency bias, or we have like the halo and the horns effects. There's so many different, cognitive biases where when we think about our work, we think about, if it was a pie chart, the whole thing is that traumatic incident, whereas that might have been a small part of our day. So really kind of getting that broad aspect and not overgeneralizing, using those absolutes. People never follow my recommendations. Clients always, have a certain medical condition, etc. And I really like this quote. The expectation that we can be immersed in suffering and loss and not be touched by it is as unrealistic as being able to walk through water without getting wet. So I really like that. I've got that on my desk. So now we're getting to burnout. And really interestingly, as I mentioned before, there's kind of a bit of research showing like, is it burnout or is it bored out? When you're feeling apathy, when you're feeling unmotivated, is it actually that you need to change up your routine, or is it that you're burnt out? And it's super, super important to know because if you're burnt out, you need to do less. If you're bored, you kind of need to do more. So when we think about what does burnout recovery and prevention look like, doing less, doing less. So this is hopefully going to be really practical, but thinking about what we can take away for making ourselves a not to-do list. I don't work after 5 p.m. I don't see clients who are, have that medical condition, which is not always possible, but where you can. But it's really important to actually write it down because if you write it down, you cement it in your mind, you give yourself permission. Brene Brown has a really lovely exercise where she gets people to, I think she talks about it in one of her books, Braving the Wilderness. She gets people to actually write down a permission slip. I give myself permission to leave at 4 p.m. today. And there's something magical about actually writing it down or sharing that with other people, where it kind of makes it more real. It also externalizes it. So suddenly it's not, oh, I'm giving myself permission. It's, oh, well, this permission slip, this written thing, that's giving it to me. So writing it down, super, super powerful and super magical. Also on the theme of doing less, routines and habits are associated with less cognitive load and less decision fatigue. So if we're thinking about things like implementing exercise, if it's, every Tuesday at 6:30 a.m. I go running, then it actually requires less decision making than, okay, on a Sunday night, bringing up the gym calendar, looking at, well, what can I do this week? If you're able to have a routine and a habit, if your lifestyle and your family life enables that, habits are so, so powerful. Yeah, less cognitive load, less working memory required, less decision fatigue. So we're more likely to do them, which is great, especially if it's something like exercise, which can be a protective factor. But we're just not adding jobs to our day. Because it's really fascinating when we talk about burnout. If you ask people what you should do about burnout, people always say to do more. They're like, oh, I need to exercise more. I need to buy a new cookbook so I can be eating better. I need to see my friends because I've been in social withdrawal. So they just kind of give you this list of more, 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 more. But actually, we really need to do less. So what can you take away? And also, what can you make into a routine and a habit? And there's so many sort of, great psychology strategies around forming habits. There's a technique called habit stacking where you pair something with something that you already do, so that it requires less cognitive resources to be able to enact. Point number 2 on the slide, drainers and sustainers. So it can be a really lovely exercise to actually sit down with a notebook and think about, well, what are all the things in my job that really drain me? And what are the things that sustain me? So drainers might be certain presentations, it might be paperwork, it might be clearing out your inbox, it might be washing down the sink, it might be, spending time with a certain colleague. And on the flip side, what are my sustainers? What are the things that give me energy, that give me, enjoyment and pleasure and fun and purpose and meaning and all the good stuff that actually is a real protective factor against burnout? Because we want to be getting that stuff about 80% of the time. So from your drainers and sustainers list, this is also something that can be really nice to do with like a team in a workplace and then to actually kind of share them. But from the drainers list, what can you delete? So what can you actually decide is not worth doing? What can you delegate to someone else or delegate to a support person or delegate to an app or delegate to AI or delegate to, so many different possibilities. What can you delay? So there's a wonderful book called Getting Work Done. I think it is Getting Work Done. And he talks about the things that drain us. He calls open loops, which is basically, so every person in their brain has a mental workbench, which is like all the things that we're keeping track of that maybe are coming up, or they're just like the mental load, like, oh, got to buy that birthday present, got to go to the shops after work. Also the car needs petrol, like the things that we haven't really written down that we're just holding in our brains. And so he says that the more open loops you have, the more burnt out you are, because you're constantly reminding yourself of information, which takes out cognitive resources, which makes you feel out of control because you're constantly like, oh, don't forget, don't forget. So it's sort of very chaotic and frantic. Yes, if we can get things off our mental workbench, and delaying them is one way to do that. Actually, I've been thinking every single day for the last 6 months that the car needs a wash. I'm actually just going to decide to wash the car in December. I'm going to write a note in my calendar in December so it will pop up so I can actually feel like I'm free of it, because it only works if you'll be reminded at some point. So delay, do it. What are the things that you're actually putting off that would take, a short amount of time, and working out why you're not doing them. And decide. So also a decision that needs to be made. That's an open loop that sits on our mental workbench, that takes up our cognitive resources, that makes us feel stressed because it's just sitting there and we have to remind ourselves of it, and we're churning about it and we're chewing on it. It's actually making that decision. And for some people that might be around something in their family life. For other people it might be around what they're going to spend their training budget on, this year, all sorts of things. And I just thought I'd mention subtraction bias. So this is one of my favorite cognitive biases, and psychologists love cognitive biases. And so subtraction bias says that when asked to solve a problem, people will always do something rather than take something away. So there's a very famous study with like soccer goalies. I think that's, yeah, the person who stands in the goal. Um, and statistically, if a goalie stands completely in the center and does nothing, they are more likely to save the goal. Whereas what goalies do, I don't know this, but the study taught me this, is they have to kind of decide, do I want to go left or right? But statistically speaking, they actually lose more if they choose one, and they should actually just stand still in the middle. But of course they don't, because if a goalie was just standing still, they'd kind of look a bit silly, or the crowd wouldn't be entertained, or they wouldn't feel like they're doing something. And it was fascinating. Even when they told these soccer players, you will have more chance if you just stand still. Most people don't do that, which I think is really fascinating. There's another study with soup where they oh gosh, how'd it go? So they gave people like a soup recipe, and it was really bad. I don't know if they tasted it or just read it, because it had some weird ingredient. It was like a country style chicken soup, but then it had, randomly like wasabi in it, or something that, really didn't match. And no one in this study, or very few people, actually thought, well, let's take away the weird, kind of thing that doesn't match. They just kept adding more. Oh, let's try more salt, or let's add more carrot, or let's do this. So our brains as humans, we're so biased towards thinking that action and doing more is going to be more helpful, is going to help us solve the problem, is going to have more impact than either sort of doing nothing or staying still. So I really like to think about this, like when we're feeling exhausted, when we're feeling burnt out. Also, even, to be honest, I mean, I'm not a medical professional, but like it does apply to doctors and things like that. That subtraction bias has also been studied, that it's about, giving more and more, medications or strategies or exercises rather than taking something away, which I had in my own life recently. I sit for a living as a psychologist, and I was crossing my legs all the time, and so I've got this like really sore knee, and my physio was giving me like all these exercises, and that was great. And then one day he was like, how about you just don't cross your legs for a month? And I did that, and I felt really awkward, and I had to get like a little extra cushion to prop myself up. And that was great. And that was fantastic. And I just think that's another example of, sometimes we don't need to just add more and more and more. We just need to take something away, or we need to do less. So I love subtraction bias. So really think about, what can you do less of? What can you take away rather than what can you do more of? Another way that we can sort of look at burnout recovery and prevention is challenging our perfectionism. So are you comfortable giving 80% effort? And if you're not, really looking at, where did that come from? What was your schooling like? What was it like when you got 80% on a test rather than 100? Why does 100 really matter to you? What does it mean about you as a person if it's 80%? Remembering 80% is not 20%. If that actually feels really uncomfortable, if you notice, oh God, the thought of doing 80%, that's terrible. Really kind of challenging that, and that might be something that's needed within your own therapy. But this idea, it's actually unsustainable and often impossible to give 100% all the time. And so we need to be sort of comfortable giving less. And of course, you choose appropriately what you give less to. I don't think you should give less to a face-to-face client. I do think you should give less to rereading an email 10 times to make sure there's no, typos in it, to make sure people don't think less of you in the workplace. That's the sort of stuff I'm talking about, not necessarily client outcomes. Unhelpful thinking styles. So again, psychologists, we love these. Are you labeling yourself? Do you use any labels like I'm a failure? I'm not good enough. Any of those kind of labels. Black and white thinking, or all or nothing thinking. So I'm a success or I'm a failure. It was a good day or it's a bad day. I was helpful with that person or I was unhelpful. Often the black and white thinking can mean that we do feel inadequate a lot of the time. So then we, overexert ourselves to challenge that or overcompensate for that all or nothing thinking. So really important to challenge some of those thinking styles, which therapy can be really helpful with. Mind reading. So this thinking style says, I know what that other person's thinking. I know that client doesn't like me. I know that boss thinks I'm hopeless. Therefore, I'm going to do everything I can to prove otherwise. I'm going to go above and beyond. I'm going to stay back late. I'm going to reread that email 20 times. I'm going to research on the weekend. I'm going to do all these things to prove. But this person might not be right about that, because when we're reading someone's mind, the reality is that we don't know what they're thinking. And overgeneralizing. So this is where we use those absolutes. So always, never, etc., which can just actually add to our stress, particularly if they're not logical or factual. Point number 3, remembering that rest makes us more productive. So many people who struggle with perfectionism really struggle to switch off and to rest. And that means that even when they're getting rest on the weekend or on a holiday, they're still thinking about it, or they're feeling guilty for it, which means that the rest isn't restorative. So that very final point, rest isn't restful if you feel guilty doing it. What next? Using the power of yet. So, saying to yourself, I am a physio learning to, can't think of a single thing a physio would do. I'm not a physio. I'm a physio learning to help knees. Or I'm a psychologist learning to do EMDR. Or I'm a psychologist learning to do schema therapy, rather than I can't do it. I've just done the training. I have no idea what I'm doing. And, that's our internal narrative, and how we talk to ourselves, and the presence of a really strong inner critic absolutely contributes to burnout, because we never feel good enough. Then we constantly feel stressed, and we constantly feel like we need to overcompensate for feeling like we're a failure. So really use that word yet, put it into everything. Instead of I can't drive, I can't drive yet. Instead of I can't speak French, I can't speak French yet. Often just actually changing the way we talk to ourselves and adding some self-compassion can be really protective. Time-based goals versus outcome-based goals. So that means, so a time-based goal is I'm going to work on this report for an hour. An outcome-based goal is I'm going to finish this report. So it's about the ending, it's about the outcome. The great thing about a time-based goal is we can always win, because we can always, regardless of how much work we get done in that time, if we do it for that time, we can feel good about ourselves. We can have a sense of achievement. We can feel satisfied. We can feel proud of ourselves, all things that are really important to protect against burnout. So really thinking about when you're setting up your goals for the day, are they actually output based? I need to see X amount of clients. I need to clear my inbox completely. I need to, and can you change them to be something that's time based that you can succeed at? And the final point before the bold one, stop frantic fussing. So I see this all the time in people who are burnt out. So frantic fussing is the term we give for when you're kind of doing like that busy work. So I'm just going to check my emails, I'm going to check my calendar. I'll go to the sink. Does anyone want a cup of tea? I'll put more paper in the printer, like all things that we're not actually achieving the thing that we're avoiding or we're putting off. It makes us feel good in the moment because we think, excuse me, because we feel like we've done stuff, right? Like you feel productive, it feels good, but you just exhaust yourself because you've spent the whole time, doing stuff. But you don't feel any better because you didn't actually do the thing that was the actual source of stress for you. So yes, frantic fussing, really something we wanna stop. Number three of burnout recovery is reconnecting with our passion and purpose. So questions such as, why did I enter this profession? Why am I a doctor? What did I love about it? Why am I still here? Answering some of those questions can help you, reconnect, and that sense of job satisfaction and that sense of purpose and meaning is a protective factor against burnout. Reconnect with peers and improve your social relationships at work. So when we feel more supported in the workplace with peers, colleagues, leadership, that's a really good thing. And I like this line, make peace with that colleague. We've all got one. I don't, I work for myself, but I am that for myself some days. But make peace with that colleague. You know the one that I'm talking about. Maybe they've come to mind just now. And Brene Brown has a really lovely quote that says, people are hard to hate up close. So the more you actually lean in with curiosity, the more you actually think, well, how can I get to know this person who ruins my day, who's cranky, who's irritable, who I avoid? What's actually going on for them? What are their kids doing at school? What are they doing on the weekend? What are their hobbies? The more we actually flesh out someone as a whole person, the less likely we are to have stereotypes or to make those quick mental assumptions like, oh, that's Susan being Susan again. Things that actually just drain you in the workplace. Another way to reconnect with your passion at work is to practice the three good things activity. So finishing the day and noting down what are three things I enjoyed, what are three things that went well, what are, or even just not necessarily things that went well, but just things that you appreciated. So I appreciated the smell of the coffee, that was a really nice moment. Anything where there's mindfulness, where it's getting you to kind of reframe the workplace that you're in. Because as human beings, we have a negativity bias. So we're so primed to see all the things that are going badly. And biologically, evolutionary wise, that has a really important function. Like obviously, if we're on the lookout for threats, we're more likely to stay safe. So it absolutely has a purpose. But the problem is, the society that we live in, we're not exposed to all those threats anymore. We don't need to be on the lookout for the things that would cause a genuine fight or flight response. So we actually want to be looking for some of the positive things and sort of switch off that negativity bias. And the more we look for positives, the more we'll find them. There's so much evidence. From neuroscience that we can actually really train our brains to find the positives. So it's a really good activity. And I think that's one people, when they think about gratitude journals, they sort of think of like toxic positivity, like, oh, I have to actually minimize the negatives. And it's not that at all. The two can coexist. It's just about how can I actually, because if you look for them, you will find them, whereas toxic positivity says the other stuff doesn't exist. And gratitude is not about that. Creating a well done wall. So, things that you can return to. I have a Word document on my laptop where I sort of copy and paste when I've gotten nice feedback or emails from clients or things like that. And when I'm having a really bad day, when I'm feeling really ineffective, when I'm feeling really burnt out with the work, when it's been a particularly trauma heavy day, I return to this and I read it and it gives me a boost. So yeah, people call them their well done walls, their go me jars. Back in the day, it might have been a physical jar. Now there's all sorts of apps and, things you can do in your phone But yeah, really nice to have something to go to actually also challenge some of those negative thinking styles, right? Because all or nothing thinking is going to say, well, that went badly, I'm a failure. So having something to actually kind of provide some alternative evidence, almost doing a little bit of CBT work, that can be helpful. And finally, creating a reverse bucket list. So rather than a to-do list, it's a to-done list. So all the things I achieved today, because sometimes if you're burnt out and you're feeling ineffective, it can feel like you actually didn't achieve anything that day. I know why, like when I've had like a really report heavy day and I've spent 8 hours, on this one assessment report, I go home and I just feel like I haven't done anything because I don't have anything to sort of to show for it. I didn't see any clients that day, or I didn't finish the report, or I didn't reply to the emails. So actually kind of making a list of what you have done. So I worked on that report. I scored that psychometric. Reminding yourself of all of those things. Number 4 on burnout prevention and recovery is to improve your boundaries. So don't be your profession for family and friends. I think psychologists, we get it easy because we're literally not allowed to under our code of ethics, but it's different for physios and plumbers and GPs and, people that may not have that in their ethical code. But it just means that you're not switching off from work. You're not actually getting that kind of real rest. Stakes are high. You don't want to let family and friends down. So, you know, how many times have you offered to, research something and you've done that outside of hours, or, they've come to you and, oh, young Bethany is really struggling at school. Lucy's a psychologist. Let's talk to her about, strategies, and just means that you're kind of doing more work, which might be okay, but can like think of it as work. Unpaid work is still work. Volunteer work is still work. The mental load for family and friends is still work. Um, Empathic imagery. So this is where, if you're having a tough day, or, you've experienced some vicarious trauma, how we process something in our mind. So if we're seeing it as if it happened to us rather than happening to them, we're more at risk of burnout and vicarious trauma. So really trying to sort of, if you're a big imagery person, picturing something as it happens, like you're watching a movie, not like you're the main character. Boundaries can also include things like the physical setup of the space. So how close do you sit to a client? How much can a client or a patient see your computer screen? And does that bother you? How much space do you have to move around? These are all really important things, the actual physical setup of your space, the chairs, the placement, all sorts of these things. Um, there's a great thing called postural mirroring, which is, when we're co-regulating with a client, we're often taught to mirror, right? To lean in, to match their body language, match, what they might be doing. And it's always to kind of co-regulate. But gosh, it takes a lot from us. When we're co-regulating, the other person is borrowing our nervous system. They are coming down to match our calm. That is really lovely to be able to offer. It's a great skill to have. But sometimes it can actually mean that you're giving more than you have capacity for. So postural mirroring is actually about like, can you do the opposite? So rather than leaning in, can you sort of sit back? Obviously, still being kind and compassionate and empathetic, but actually really sort of intentionally thinking, I'm really getting sucked in here, or this is really distressing what I'm being exposed to, and doing things to actually sort of create some psychological or physical distance from the person. Learning to say no without guilt. If only it was that easy as a dot point on the slide. I think it's something that we all so struggle with. But learning to say no, thinking about actually what are the consequences if I say no? Is the world, going to end? Also, if you're going to say no early. What people pleasers do is they say yes up front. Yes, I can help out at that barbecue. But then, even though they kind of know they don't have capacity, and actually that's probably going to clash, but I feel really uncomfortable saying no, so I'm going to say yes. And that makes me feel good in the moment because they're so pleased that I'm going to help out this barbecue. And then it gets closer and closer to the barbecue. And then you say no because you really can't do it, or you're so actually now resentful that you said yes in the first place. So you say no close to the barbecue. And actually, when you think about it, your original plan was to be kind and helpful by saying yes. You've actually done the opposite by saying no, like closer to the event. And actually, it would have been the kinder thing to say no earlier so that they could make other plans, so that they could, do whatever they needed to do. So that's like a really big tip. If you're going to say no early. There's also a really nice, it's not on the slide, but there's a really nice activity called or not activity, but it's called the yes, damn, no, yay effect. And I got this from a podcast. This has no evidence in science. Take this with a grain of salt, but I thought it was fantastic and I've implemented it in my life. So it's this idea that when we say, so it's yes, damn, no, yay. So when we say yes, we feel good in the moment. I've said yes, I've helped them, they're excited, I feel good. When it comes to the event, we're like, oh, damn. So we say yes initially and then, oh, damn, later. And then when it happens, we feel, oh, I don't want to go. Why did I say yes? God, where, blah, blah, blah. What happens is it means that we only ever kind of get the negative associated with the saying yes, and we never get the positive associated with saying no. So what this little kind of technique is that you say no, but then you still put the thing in your diary. So you still put the trivia night in your diary or whatever it might be, so that when it rolls around and you don't have to go because you said no, when you don't have to go, you get to have the like yay effect. So you've said no, but now you get the yay. And so it's a way to actually kind of reinforce that saying no can bring on a good feeling, not just a bad feeling. So yes, I hope that makes sense. Yes, damn, no, yay. Really quite powerful. Actually, still put it in your calendar. And then yeah, just reinforces that saying no makes you feel good because you get that positive effect. Oh yes, I don't have to go out tonight. I can actually stay in or whatever it might be.
Lucy, there's a really good question in the
Mm.
chat, and it's a tricky one. And it says, for those of us in management roles in health, we often sit in the uncomfortable position of pushing staff to work, do more. Or if we protect our staff, we're often the ones to fill the gap. And if no one does it, then patient care suffers. Any suggestions? So trying to respect boundaries, whereas stretch boundaries. And do you have any advice on this?
I think I would say, I mean, my gut instinct is to say that it seems like that workplace then actually doesn't have capacity for that. So if it's either that the individual staff member does it and they take a hit, or if that person is protected, the sort of manager takes a hit, why does anyone have to take the hit? I think that really goes to show there's a systemic issue there where the capacity of the team is outweighed by the demands on the team. And so I think in that case, like it's actually about changing the structural things, less clients or reducing the workload itself because we're human beings, we're not robots. We can't just sort of take on and on and on. And sometimes that's really hard, right? Like I was working in a service where, our books closed and I was really worried, well, are people going to end up on the street, because of that? And that's a real genuine concern for so many of us is if we close our books, if we have a wait list, people will be suffering. But then we really have to put it in perspective, is that our role? If we're in the private sector, it's not my role as a private clinician to cover the shortfall left by Medicare, for example. If you're in the public sector, it's not your role to cover the shortfall left by, the government budget. So I think being really clear to those, up and up and up the chain about what the impact is. Because also, if people are taking on more than they have capacity for, their workplace effectiveness will decrease. So I think in that question, it was saying, you didn't want to compromise patient care. But if a burnt out person is giving care, that is compromising patient care. And also, in the psychology world, like it's really important for us because if we're burnt out, and we're dealing with people who, might have attachment issues, might have, trauma by omission. So they didn't get love and nurturance and care and kindness. And now they're stuck with a clinician that is, resentful and fatigued and burnt out. We're actually just contributing to their trauma because we're not giving them we're not giving them what they deserve. We're actually contributing to that trauma of omission. So I think, yeah, I'd really challenge that idea that patient care would be compromised if you didn't take on the client. Because also think about if you did, what sort of version of care are they getting? And that's a really good question when, we're thinking about saying, no to something. Sometimes it can be helpful to think, if I said yes, what version of myself would this person be getting? So if I said yes to volunteering at my school tuck shop, what version of myself are these kids getting? Because actually, if I'm going to show up and I'm cranky and I'm resentful and I don't want to be there and I'm not looking them in the eye, they're actually going to suffer more. So that's my take. I hope that's helpful.
Yeah, that's useful. I guess there's also like how much can we encourage people to change?
Mm,
Because sometimes people don't want to change, and staff might not want to
definitely.
change. So there's quite a few issues involved in that question, isn't there?
Mm. And I think if it's not necessarily just about capacity, if it's about other things that are at play of why the person doesn't want to take on this extra workload, does it actually not at all have to do with burnout? Does it have to do with their level of competence? Does it have to do with, do they actually have a really harsh internal critic that says, oh my God, I'm going to stuff it up? Does it relate to a past trauma of theirs? Well, the last time I worked with a client who had an eating disorder, I don't feel like I helped them, therefore I'm going to avoid, further clients. So yeah, is it avoidance because of burnout, or is it avoidance because of, personality factors, because of self-criticism? So there certainly could be, yeah, a lot going on there. So also kind of maybe exploring that with them, if it's not just a workload thing.
Yep.
Yeah.
Thanks.
Okay. Boundaries versus requests. So a boundary is always about what I'm going to do. So I'm going to leave this conversation if I'm continued to be yelled at, rather than please stop yelling at me. Boundaries are much more effective than a request. And also setting a boundary. So often it's not setting it, it's the maintaining it. So I said I'm not going to stay after 5. Oh, but can you? Oh, but what about? Oh, and there's someone waiting. So just keeping that in mind, that often the maintaining it is the more tricky bit. And there's some great stuff online about I statements. So talking about how that would impact me, not what you're doing, all sorts of things like that that can help you if you struggle to set boundaries. One of the other reasons that people experience burnout is because workload is just too high. Sometimes that is because of the, like genuine workload, or it can also be because you're procrastinating a lot of the stuff that you do need to do. So if that's a source of overload and of work burnout, because actually you had the time but you just didn't get the work done, then it's really important to identify why. So some of the common examples might be, are you missing resources? Sometimes then people feel like they can't start. Are you worried about disappointing someone? Does fear of failure, is that getting in the way here? Is perfectionism getting in the way? Is it that you lack the experience, like you actually just truly don't know where to start? Is there some other type of avoidance? Is it an ADHD thing? Is it an executive dysfunction thing? Is it chronic health, issues? Is it apathy from depression? Is it, rumination from anxiety? Like, what is the reason getting in the way of why you're not doing that thing? Only if it's not just a genuine workload thing. If it's you had the time, but you just sort of spent it frantic fussing, and or you didn't get that thing done. Number 6 of burnout prevention is to get variety. So can you add new things to your work? If you can't, can you have new things outside of work, hobbies and things like that? And yeah, as much variety as you can. If you are really burnt out, is there anything you can do to reduce your executive functioning demands? So, if you're working all day and then you're going home and you're cleaning the house, and then you're, cooking for people, and so you're just actually on from about 6 a.m. till, midnight when you collapse into bed, and then have that revenge bedtime procrastination and you're on your phone. Can you get a cleaner? Is that within your means and capacity? Can you buy pre-chopped vegetables rather than, spending that extra, half an hour doing that yourself? Really thinking about how you can be kind to yourself based on what's within your means, your values, because obviously there's lots of things that are at play there. Plastic, finances, all sorts of things. Utilizing tech, so apps, checklists, notes, anything you can do to get it off the mental workbench. What can you automate? AI note keeping is really big at the moment in the industry. It's not something that I do, but I'm certainly looking into it because of the time saving capabilities. And obviously we need to make sure, APRA's aware and compliance and all sorts of things. But what can you, again, do less of? Because, sometimes, I hate to say it, but we can be a bit of a sucker for punishment, because we want to feel like we're doing something. So even if we do something the long way, or even if, even if we do something and it's exhausting, sometimes actually that gives us more than it takes. So yes, it takes our energy and our fatigue and things like that, but it gives us pride in our work. It gives us feeling like we're actually being productive, which is powerful. Number 8, reduce context switching. So there's a lot of evidence that time time chunking, so where you sort of batch tasks. So, okay, I see clients for half the day, then I write a report for half the day, then I do my notes at the end of the day, we're more effective than if we're constantly sort of switching between contexts. Contexts can be, different meetings, finance to marketing, or it can be sort of deep focus versus shallow focus. So shallow focus being, emails and, invoices, deep focus being report writing, making a presentation. So really looking at if that's the way your brain works. Some people actually might prefer the opposite, but a lot of research does say that batching is better. Creating a third space ritual. So, third space, there's a great book about it called Third Space. And it's this idea that the space we're in is the first space, where we're going next is the second. And in order to actually effectively transition between the two, we need a third space. So the spaces can be meetings, roles, locations, going from doctor to spouse, going from adults to kids, because you require a different energy level or playfulness. And so a third space ritual is anything that puts a full stop on it. So for example, for doctors, maybe washing your hands between clients, not for, hygiene reasons, although I'm sure that's great, but to actually have something that is a ritual, that is a full stop in your brain. That one's done. Now I'm moving on to the next client. This was really interesting in COVID because a lot of people, their commute was their third space. And so when they stopped getting a commute, they actually stopped getting that transition time. And the transition time is, it's that full stop. Sometimes we can ask some reflection questions to help it along. So what went well today? Or setting an intention. So before you get home, when you're sitting in the car, how do I want to show up in this next space? So it might be, I want to show up as a playful mum, or it might want to, I might want to show up as a keen and enthusiastic webinar participant, but anything that actually, if you give some intention to it, can put a full stop on the day and help you actually go into the next space, like without baggage, basically. Get better sleep. So I won't go through these because usually we know them, we just don't do them, but you're very welcome to take a screenshot, or I'm very happy to send you a copy of the slides as well. If you wanted to have a look at this list, just send me an email. But, often because we get less sleep when we're burnt out, one, because of the cognitive rumination, two, because of a lot of, the hormonal stuff and the, adrenaline and stuff that's going on. Also because of the revenge bedtime procrastination, we're reclaiming that autonomy in the nighttime, so go to bed later. So all these things can mean that we're getting poor sleep. And then that, of course, just compounds everything, makes it worse. But very important to note, sleep alone can't cure burnout, because burnout is caused by what you do in the waking hours. So burnout is caused by taking on those commitments. It's caused by, the exposure to vicarious trauma, all those sorts of things. Just two more before we finish. Addressing your own schemas. So there are so many reasons why people might burn out from those individual factors. So for example, family of origin issues and attachment issues. So do you go into the rescuer role because that's what was really instilled in you growing up, that was a good thing or made you a good person or was required by your family? Do you go into the peacekeeper role? Do you self-sacrifice? Do you put other people first? Do you have approval-seeking behaviors? Do you go above and beyond to make sure that you're liked or you're needed? Do you feel imposter syndrome? So that makes you kind of do more work. Was your affection conditional on achievement growing up? And so now you've learned that the only way I can feel good about myself or feel good enough is when people are commenting on how much, how hardworking I am, things like that. And how does that show up? Does it mean sessions go over time because you're in that rescuer role and you're just so desperately trying to sort of make this person feel better? Does it mean that you set your fees lower than potentially you should? So then you have to see more clients and you're burning out that way. Does it mean you avoid, difficult conversations to avoid upsetting a client? In psychology, we have a term empathic confrontation, which is, in a very kind, loving, compassionate way with an understanding of why something has happened and being very trauma informed if it's a trauma response, but still being able to say this isn't okay, or there is a barrier here, or there's a blockage here, or so avoidance of difficult conversations can also be related to some of that family of origin stuff. Number 12, looking at your internal rule book. So some people have internal rules, things like I can only rest when I've earned it. If I say no, that means I'm letting someone down and that means I'm a bad person. If I don't do it perfectly, it doesn't count. People who rest are lazy people. If you've got any of those internal rules, really working hard to challenge them. And sometimes, yeah, therapy can be helpful for that. And just a really quick note on self-care and self-regulation. So we often talk about self-care, and it's super, super important. But self-care, we can think about it as like with the analogy of a car. You know, if you're the car, then self-care are those ongoing maintenance things that you do. They're often boring and repetitive, you know, eating well, getting good sleep, you know, having your hobbies, getting all that kind of classic self-care stuff. But self-care is actually very different to self-regulation, which is what have you got in your back pocket to re-regulate if you are distressed, if your nervous system is dysregulated, if you've had a hard day, if you've just had a hard conversation, but you really have to go to your next patient. So these are things that are immediate rather than the ongoing maintenance. So I think, yeah, I've said here, self-care is like getting oil changes and adding petrol to the car. Self-regulation is like using the brakes, stopping at a red light, things like that, immediate distress relief. And on the slides, there's a bunch of different things, but you know, breathing is the most common one that I hear. I'm a person with ADHD. I hate breathing because my mind is just going there. I actually need something really tangible to kind of focus on in order for that to work. I hate breathing. um, so things like, you know, things that help me, you know, people do this with kids, which can actually be helpful for you, right? Like if you're with a client and that person's distressed, but actually you're distressed, or you're struggling to co-regulate, do a regulation activity with them, and then you get all the benefit too. But things like, you know, shape breathing, so you know, drawing a shape. This is a really good one with kids. Finger breathing, so breathing in as you go up, out as you go down, and doing the two hands. Color counting, so what's all the red things I can see in the room, what's all the blue things I can see in the room, stuff like that. That's very sensory based. Mental distraction games. I do this before I get vaccines. Like I pick a letter and then I think of every movie I can think of starting with that letter. Or I go through the alphabet, you know, for vegetables, you know, A for apples, B for bananas, C for carrots, just anything that's actually distracting and calming and soothing in the moment. Grounding exercises, most people have heard of the five senses, you know, five things I can see, four things I can hear, three things I can touch, things like that. Using music, using your senses, you know, sour candy, you know, can be really helpful because it forces you to focus, right? Holding something warm, that's also, you know, something. Imagery exercises. So if you've ever heard of safe place visualization, where you sort of visualize something that is calming and soothing. For people with ADHD, often it's not a calm environment. It's an activity that they love, you know, like playing with their dog rather than just sitting on the beach. Because for me, if I had to picture, you know, sitting on a beach, that's boring. That's my mind's just gonna go in a bunch of places. There's nothing to focus on. I wouldn't find that calm. I know that I've probably got a lot of productivity guilt myself, so actually just lying down doing nothing would probably make me feel bad. So it's fascinating, you know, how sometimes we can guide clients to do something that actually might not be helpful for them. So, you know, actually really, yeah, leaning into that. What is it that they enjoy, not just something that is calm. And challenging those thinking styles, you know, when you're really distressed, actually, am I being black and white here? Am I mind reading? Am I overgeneralizing? Things like that. And then very quickly, just before we finish, I just wanted to have a note that, you know, in burnout, we talk about self-care, but really it so often is about community care. You know, do we have chances to debrief? Is the systemic things working for us? Do we have trusted people that we can rely on? Things like that. So often more important than actually what we as individuals can do at home when we're working in organizations. And with this is the self-care wheel. So when we're thinking about self-care, actually, you know, there's physical self-care about, you know, sleep, exercise, stuff like that. There's also emotional self-care, which is, you know, more about some of the classic things you might hear about, the bubble baths, the massages, and they're not bad. Like people, I think they sort of sometimes make fun of them as self-care. They're certainly not bad. They're not an emotion regulation strategy. They're a self-care, you know, ongoing maintenance strategy, but they're also only one sort of slice of the pie. And if you're only getting that slice of the pie, then other things will be suffering because you're not having good boundaries. You're not kind of doing any of those other things. And I've got a little self-care assessment, so you're welcome to scan the QR code or get this from the slides or email me for a PDF. But it goes through those 6 domains and there's sort of like questions so you can get a total score for each. So you can work out what's my highest domain, it might be physical self-care, and what's my lowest domain? It might be emotional self-care. So you're very welcome to do that. Um, and I just thought as well, I would just share some things that I personally do to prevent burnout in my own life. This is all, completely true. I'm very happy to answer any questions about it, but I have a rule. So sky before screens. So when I get up, I don't go on my phone first thing. I make sure I see the sky. And that just means for me, I feel more in control. For me, it's actually a magic little rule because I feel like I'm in control of my day rather than being, chained to my phone or being, because if you're sitting in bed and then you're on your emails but again, that wouldn't work for everyone. Some people like a gentle start up and they like to stay in bed and stay cocooned and sometimes they would go on their phone then, but it doesn't work for me. Nothing dark after dark. So I'm sort of the person in my family that people will kind of ring for advice about, oh, cousin Tyler's just got his ADHD assessment. Should we, tell the school, blah, blah, blah. And so I have a rule that within my family, I don't, nothing dark after dark. So there's certain family members that I don't accept phone calls from because I know it would upset me or because I know it would be really draining. There's certain topics that, I may not cover. That's just a personal boundary for me. I really focus on the time chunking, not the time confetti. So I'm very much um, X number of clients, in the first half of the day, then report writing time in the afternoon, or vice versa. I have a certain limit, like number of clients that I see, which again, private practice, there's a privilege there for sure. My own therapy to manage perfectionism, not seeing certain presentations, making sure I get regular peer supervision. And then this one, maintaining an identity outside my career. I think that's really important. I'm part of a run club. No one knows what I do for work. It's so nice to be Lucy the runner or Lucy the, the embroiderer or Lucy the sewer or Lucy the photographer. And that means that I don't sort of see my self-worth. If it's a pie chart, it's not coming from being a psychologist, it's coming from all these other things, which means I do have that more psychological distance at work. So I can switch off better and I ruminate less because it's one part of my day, but it's not my entire personality. Um, and there's a term called sort of compassionate detachment. So we can still be warm and kind and loving and caring people without being completely absorbed into something, where we're walking alongside someone, we're walking with someone rather than being in their journey. And also regular regulation. So as I said, love sensory stuff, love saunas, love journaling, all sorts of things that are part of my self-care plan. All right, so I think we've sort of got about 10 minutes for questions, so I'll hand back over to Leonie, but I'll also put up, if you wanted to get in contact with me, my email is there. I'm very happy to answer any questions or share slides.
Thank you, Lucy. That was great. Really sensible and relevant kind of information for all of us in primary care. I might just circle back on some of the questions we've received tonight. So the first one on the moral injury and where it fits on the continuum, I guess, of trauma. Just have you got any comment on that?
So the injury itself is not necessarily considered a trauma. So we can be exposed to things that would constitute moral injury. So we can be exposed to child sex offenders. We can be exposed to racism. But where it would fall on the continuum is then how much does that impact us? So for example, if you are in a car crash, people can be in a car crash, but then not develop any trauma symptoms from that. But if you have a car crash and then you're thinking about it, you're having intrusive thoughts about it, you're having flashbacks to it, you're dreaming about it, then we would consider that a trauma response. So there's a really lovely quote which says, trauma is not what happens to you, it's what happens inside you. So the same person can be exposed to the same thing. You could have, 5 members of the police force who are all exposed to, something that can cause a moral injury, like being exposed to, child sex offenders, but everyone might have a different response. Something else that can sort of be impacted is where there's sort of like if you're exposed to unfairness or, workplace prejudice and things like that. But again, it's not what you're exposed to, it's how does that actually impact you? How does that change your worldview? Which then sort of determines, is it a trauma response? Does
Right.
that make sense?
That makes sense. Thanks. Another question we've got. It says, great talk, Lucy. Might be jumping the gun, but any tips or ideas on how practice owners can best support their GPs?
So I think, making sure it's a psychologically safe environment. So many people do all the things. They check in, they do calendar management, they, offer debriefing opportunities, they offer CPD. But actually, it's not the offering that counts. It's, do you have a psychologically safe workplace where the GPs can say, actually, that wasn't good, or actually, I do need help here. And so that comes from, being vulnerable. It comes from asking for feedback. It comes for, showing that you're intentional about your questions. Like, oh, I've noticed that you're seeing a lot of clients, who are elderly. How is that impacting you? Because maybe, showing that you notice these things, obviously, confidentiality and stuff like that. So I think that, yes, very much it's not about what you do or what you offer. It's about how is that received? Do you have a psychologically safe workplace where people can actually be honest? And developing that is about, how do you respond to feedback? Yeah, how do you show someone, that you care about them? Because I think a lot of people think that, people are motivated by the extrinsic stuff, the salary or the benefits. But often it's so much more, especially people that go into caring professions because they're caring people. It's about the culture, it's about the environment. Do they enjoy showing up to work? Are there things that could be changed? And then developing that trust. So if I offer you feedback, does it get enacted? Do you remember it? Does it get written down? Showing that it's not a token sort of check-in. It's something that you actually do want to change. Asking for their opinion too. I think so much of the time, like I've seen in large organizations, people will get like the feedback about what's not going well without the people who gave that feedback contributing to the solution. So that's
Mm,
another way to build psychological safety. Like actually, what are their ideas? They're the ones who are doing it, who are going through it. Yeah, I think that's what I would
mm.
say.
And then there's also, where do the practice owners turn for their support? Like if they're always offering support to their GPs, where do they, when they're feeling
Definitely.
distressed, who do they turn to as well?
Definitely. And
Yeah.
sometimes in organizations, sometimes it can go back and forward. You can sort of provide support and receive support, but sometimes that can be quite tricky and it can also have ethical implications. So we also sort of want to look at like different levels. So if the GP is being supported by the practice manager needs to be supported by someone potentially outside of that zone. So kind
Mm,
of like going sort of out and out and out rather than this kind of sometimes messy um, yeah, where you're sort of providing support, sometimes receiving it, sometimes giving it. That can be really tricky.
yeah. Yeah. Thank you so much. That was really, really good. Just to let everyone know that this webinar will go up on the Capital Health Network YouTube page in a couple of weeks. And we just want to thank Lucy so much for such a great presentation tonight and also for the great questions from the audience. Please feel free to record 1.5 hours of educational activities to your CPD home and fill in the evaluation surveys for us. We will send you out a certificate of attendance. So thank you very much, everyone, and thank you, Lucy, and good night.
Thank you, everyone. Lovely to spend
Thanks.
the evening with you.
Thanks.